Vishesh Sharma, Assistant Professor in CVTS at UM Mehta Institute of Cardiac Research. Today we'll be discussing pulmonary function tests. The topics that we aim to cover by the end of it include the definition, the indications, the types of tests that we perform, the basic physiology and the interpretation of a PFT report once we are handed one. So this is what a normal PFT report looks like. It is divided into three parts. There's a spirometry, the plethysmography, which includes the lung volume and the diffusing capacity of the lung. This is what the modern spirometer looks like, and this is an illustration of how the patient uses the same machine. Now, what are the indications? Before any investigation we talk about, we should know what are the indications, when are we doing an investigation. So the general purpose of a PFT is to diagnose a symptomatic patient who might have chronic cough or hypercapnia or hypopnea, or in a patient who's already high risk, say history of smoking is present. It is also used to screen for early asymptomatic diseases or prognostication of patients with known diseases. It is also used to monitor response to treatments. However, symptomatic relief is the best measure to monitor response to treatments in respiratory ailments. Now, the classification of lung disease based on PFT is grossly into obstructive or restrictive lung diseases. Obstructive include chronic bronchitis, emphysema, asthma, acute bronchitis, bronchiectasis, or bronchiolitis obliterans. Restrictive lung diseases, on the other hand, can be because of pulmonary cause, which include ILD, or it could be related to your extrapulmonary, including obesity or chest wall deformities. Now, functions of PFT is grossly to evaluate all the aspects of the respiratory system, including the airways, the parenchyma, the vasculature, the bellows and pump mechanism, including the chest wall and the diaphragm, and the neural control of respiration. So, on this slide, you see the basic classification of the lung diseases and the gross classification that we do based on FEV1 and FVC, what we'll discuss in the subsequent slides. In pulmonary function tests, before we jump into the different tests, let us go through the tidal volumes and the capacities that we come across for lung volumes. So it is basically divided into your tidal volume, which is the inspiration and the normal volume of air that is inspired and expired by a patient. There is the inspiratory reserve volume, which is the amount of volume which the patient takes in forcefully. And then there is the expiratory reserve volume, which is the maximum air that the patient can expire. Based on this, and the volume that is still remaining in the lung after maximum expiration is known as the residual volume. Based on this, based on these four volumes, there are four capacities that have been described. There is the inspiratory capacity, which is inspiratory reserve volume along with tidal volume. There is the functional residual capacity, which is the expiratory reserve volume and the residual volume. There is the vital capacity, which is the tidal volume, the inspiratory reserve volume and the expiratory reserve volume. And then there is the total lung capacity. Now, pulmonary function tests grossly can be, as I mentioned previously, are divided into three: spirometry, lung volumes in loops, and DLCO. So, as mentioned previously, the three components of pulmonary function test in the standard pulmonary function test include spirometry, lung volumes, and DLCO. Spirometry is primarily used for obstructive lung diseases. Lung volumes are used to assess for restrictive lung diseases, and DLCO is used for assessing any alveolar gas exchange malformation that might be present, or alveolar gas exchange that there might be inherent issues with the same. Now, coming to spirometry, we ask the patient to inhale maximally and exhale as fast as possible, at least for 6 seconds. The first second of this is the FEV1, which is the forced expiratory volume. Subsequently, in this, as is seen in this graph, you will notice this is the first second, this is the FEV1, and this expiration that continues for the same. This is the FVC. If we plot the same in a graph which is for a flow versus volume graph, we will notice this is the inspiratory limb and this is the expiratory limb. This is where the inspiration starts and this is where the expiration is. This is the total lung capacity, and this is the residual volume that remains in the lung after a maximum expiration. In this, you will notice that there are certain, there is forced expiratory fraction at 25%, at 50%, at 75%. This becomes important in obstructive lung diseases where a coving pattern might be visualized. Anyway, coming back to the FEV1 and the forced vital capacity. Now the ratio between the two is very significant, FEV1 and FVC. FEV1 is the amount of air that the patient is able to push out in the first second forcefully. In obstructive lung diseases, it is noticed that FEV1 reduces as does FVC, but FEV1 reduces more than FVC. In restrictive lung diseases, it is the other way around. FEV1 reduces, but FEVC reduces more. As can be seen in this slide, where I have mentioned regarding the same, you will notice that in obstructive lung diseases, FEV1, FVC, the ratio is less than 70%, and in restrictive lung diseases, the ratio is more than 70%. Coming back to this, the next step, so this was basics spirometry that I have mentioned. Now, one more thing about this is the staging of COPD is also based on FEV1. And this is the gold staging, where they say stage 1 is an FEV1 of more than 80%, stage 2 is 50 to 80%, stage 3 is 30 to 50%, and stage 4 is less than 30% of FEV1. The other component of pulmonary function test are lung volumes. Now, lung volumes we can assess using 4 methods. There is the gas dilution method, which includes the helium dilution and the nitrogen washout method. There is the body plethysmography and the imaging technique. The idea is to attain a total lung volume, including the residual volume of the lung. And for that, we use either a gas, helium dilution or nitrogen washout, or we use body plethysmography, which is based on Boyle's law. Imaging techniques are based on CT and X-ray, where the volume of the lung, total volume of the lung, can be deduced on CT images or X-ray images. Again, as I had mentioned, this is lung volumes and low total lung capacity points towards a restrictive lung disease. Both FEV1 and FVC are low. FVC is lower than FEV comparatively, and the ratio is less than 70%. The third component is DLCO. Now, DLCO, carbon monoxide, is used, very low concentration. It has a high affinity for hemoglobin. It aims to diagnose diffusion across the alveolar membrane. It is based on the Fick's law of diffusion, and low DLCO is about as mentioned in the Fick's law, it could point towards a reduced surface area or increased thickness or pulmonary hypertension. There are certain factors that reduce DLCO, including anemia, carboxyhemoglobin, pulmonary embolism, diffuse pulmonary fibrosis, or pulmonary emphysema. Factors that increase DLCO include polycythemia, exercise, or congestive heart failure. So when we assess a pulmonary function test report, we have to go through this format, where we first look at the FEV1 and FVC ratio. This will grossly classify it as either it can be low or high, 70% being the cutoff. If it is high, then we are thinking in terms of restrictive disease, and if it is low, then we are thinking in terms of obstructive diseases. FVC, subsequently we look at forced vital capacity. If that is also reduced, then we have to think about it being an inherent problem of the lung parenchyma, and the vital capacity is reduced. After that, we look at the total lung capacity, and if that is also reduced, we do consider that it could be related to a restrictive pathology. Once these three are correlated, most of our diagnosis is made. DLCO is for those conditions where we feel that there is an alveolar membrane disruption, where the exchange of gases is not proper. Now, these were the pulmonary function tests that are usually done. I do want to spend a few minutes discussing some tests which are bedside tests, which are important for us, which as for bedside evaluation of patients undergoing cardiac surgery or undergoing a pulmonary surgery. Now, the first is Sabre's breath holding test. We ask the patient to take a full breath, but not too deep breath, and hold it as long as possible. More than 25 seconds is normal, which points towards a normal cardiopulmonary reserve. 15 to 20 seconds is limited cardiopulmonary reserve. Less than 15 seconds is very poor cardiopulmonary reserve. it is a contraindication for elective surgery. There is a single breath count. After deep breath, hold it and start counting till the next breath. Normal is 30 to 40 and indicates vital capacity. Snyder's match blowing test measures the maximum breathing capacity. Should take 6 attempts. Asked to blow a matchstick from a distance of 6 feet. With mouth wide open, chin rested or supported, no pursed lips, no head movement, no air movement in the room, and mouth and matchstick at the same level. If he cannot blow the air, then FEV1 is less than 1.6 liters. Able to blow it out, FEV1 is more than 1.6 liters. There was a modification of the same in which they've done it at 9 feet, 6 feet and 3 feet, and they've said that if it is more than, at 9 feet it is more than 150 liters per minute, 6 feet is more than 60 liters and 3 feet is more than 40 liters per minute. Then there is the Green and Borowitz cough test, which is deep breath followed by cough. Ability to cough, strength and effectiveness. Inadequate cough points towards an FVC of less than 20 ml per kg, FEV1 of less than 15 ml per kg, and peak expiratory flow rate of less than 200 liters per minute. Vital capacity 3 times tidal volume for effective cough. A wet productive cough or self-propagated paroxysm of coughing patient points to a patient who is susceptible for pulmonary complication. There is the forced expiratory time, where after a deep breath you exhale maximally and forcefully and keep the stethoscope over trachea and listen. Now, normal forced expiratory time is 3 to 5 seconds. In obstructive lung disease, it could be more than 6 seconds, and in restrictive lung disease, it is less than 3 seconds. The respiratory rate, it is an essential yet frequently undervalued component of pulmonary function test. It is important evaluated in weaning and extubation protocols. Increased respiratory rate causes muscle fatigue, workload and failure of weaning. De Bono's whistle blowing test, it is a wide bore tube at the end of which is a whistle with a hole which has an adjustable knob. As the subject blows, the whistle blows. Leak hole is gradually increased till the intensity of whistle disappears. At the last position at which the whistle can be blown, the peak expiratory flow rate can be read off the scale. Then there is the Wright's respirometer, which measures the tidal volume and minute volume. It is simple and rapid. Instrument is a compact, light and portable instrument. Disadvantages, it underreads at low flow rates and overreads at high flow rates. Can be connected to endotracheal tube or face mask, but you need to explain to the patient before we take him for this procedure. It is ideally done in sitting position, and minute ventilator instrument record for 1 minute and you read directly. Tidal volume calculated and divided by dividing minute ventilation by respiratory rate. And accurate measurements in the range of 3.7 to 20 liter per minute. Uses, it's a bedside PFT, and in ICU it helps weaning the patient from the ventilator. Thank you.